Okay, so welcome to UMDcast episode 5. Today we will be interviewing Dr. Feldman-Winter, a professor of pediatrics at the Cooper Medical School. Thank you very much for coming and talking with us today. We usually just like to start off by asking you to tell us a little bit about yourself, about like where you went to school, did you always want to be a doctor, and things of that sort.
Okay, first, thank you so much for inviting me. It's really a pleasure to be with you and to learn a little bit about you guys as well, the pipeline to our profession. So I started out going to college at Washington University, and there I was a bio major, but actually a double major. I was an artist as well. So I hauled my big canvases down to the art school, which was probably the best way to keep in shape during college, as well as, and I felt like the curriculum in art school at WashU at that time was so challenging. I thought I could actually do better as a strictly bio major, and actually being pre-med in some ways was even a little bit easier. But I really was privileged to be able to work with some amazing mentors that were at WashU. And one in particular, Danny Cole, who was my first biology teacher and actually became a father figure to me because I was far away from home. I grew up in New Jersey and was going to college all the way out in St. Louis, in the Midwest. And I think what struck me about Danny was not only his passion for science and really teaching me the scientific method and really thinking like a scientist in my career, but also his passion for social justice. The lab was studying organic farming, so even that was about social justice and the environment. But he also was really passionate about inclusion and equity, and actually published papers that debunk some of the previous theories about race-based medicine. So even though he was a biologist, he was really passionate about this social justice platform, and is actually was always most proud of that work, in addition to the nitrogen fixation work that we did in the lab. And then from there, I went on to study medicine at Albert Einstein College of Medicine in the Bronx. Again, just having the great fortune to have scientists that mentored me. I was really still very interested in doing basic science research at the time, and was mentored by Maddie Scharf, that was who was a cancer researcher, immunologist at Einstein, but also worked at the same time in a lab at Columbia, at Fred Alt's lab, where they really were at the forefront of identifying and understanding the immune system, which was very rudimentary in terms of the knowledge base back then. And now, some of those early breakthroughs have led to cancer treatments, as you know, the whole new frontier of cancer therapy is in the field of immunology. So in those labs, I was really there at the time when monoclonal antibodies were first being invented and developed and automated, and thinking about ways to utilize monoclonals in clinical medicine. And as you see, that too has come to fruition with the COVID pandemic, and how we, now have been able to show the value of monoclonal antibodies in treatment of a novel disease such as SARS-CoV-2. And then the other lab that I worked in, as I said, was Fred Alt's lab, and it was there that I not only worked on aspects of both the innate and antibody-mediated parts of our immune system, but we were also cloning and sequencing oncogenes, and one of the oncogenes that we cloned and sequenced and published was NMYC. And the NMYC oncogene is a very important oncogene for specific cancers, in particular neuroblastoma. And so I knew I was interested in pediatrics in medical school. And, it was because of my work with NMIC that I feel like I was almost recruited by the Children's Hospital of Philadelphia at Penn to go in what I thought was going to be starting a career in pediatric oncology and teach everyone about what we learned about NMIC, because NMIC has become a very important marker, not so much important in terms of the therapeutics of neuroblastoma, but I think it was during my residency program at the Children's Hospital that I specifically decided not to go into pediatric oncology. Things weren't so great back then in pediatric oncology in terms of the outcomes and survivals. It's a whole lot better now, and I might have made a different decision, had it been in the last 10 years or so. But back then, I think I was thinking about pediatrics and really primary care and prevention. And I loved adolescent medicine. It was just something that I didn't even think was part of pediatrics until I learned from some amazing mentors at the Children's Hospital. And then actually became a specialist in adolescent medicine. So in my clinical, what I say day job, I see teenagers. So kids not that different, in age than you guys. So I have a lot of fun with them. And the one thing I've learned from teenagers is that there's always opportunities to identify strengths and set teens off on a really good pathway to have a better life than when they first came in. And certainly now, again, with the pandemic, I think we've been very much aware of the fragility of the teenager, in our society, and how the social isolation has really been demoralizing to teenagers, how it's important it is, particularly during the period of sameness, for teens to be together and model from each other. It's sort of like, rite of passage, they have to do that. And then the other area of interest that I developed after finishing my residency and really added to practice, and, much a part of because of me being a woman in medicine and having children, learned about nutrition and breastfeeding, and recognized that as an academician, and I'm an academic pediatrician, so I've always worked in a medical school setting, I realized that there was an enormous opportunity to fill a big gap, and that is the gap that had been in existence for quite some time in terms of what medical students and even residents and other physicians know about lactation and infant feeding and breastfeeding. And so developed a real passion to try to close that gap, develop some educational resources to do that, but then got very involved with the American Academy of Pediatrics to work in their various sections, develop the section on breastfeeding. Now, currently, I'm chair of the AAP section on breastfeeding, and I should always say my disclaimer, which is that everything that I talk about today is my own personal views and opinions about things. I'm not speaking on behalf of the AAP, since very often people recognize me as being a point person for the American Academy of Pediatrics. But we have a very robust section now within the AAP, and we do a lot of educational programs funded by the CDC to try to help pediatricians learn more about breastfeeding nutrition. And then from that, got involved in quality improvement. And a lot of what I've been involved with in terms of big national projects have been quality improvement projects. And really all those topics, from the basic science research, clinical research, now quality improvement, actually all bubbles up into what I do most of my time, which is as co-course director for the Scholars Workshop, which is a 4-year integrated curriculum here at Cooper Medical School of Brown University, a fairly new medical school where we have this novel curriculum that we developed because we felt that there were lots of topics that we as physicians use every single day, but never learned in medical school. So we decided to put it in our medical school, and can really help our students become the physicians of the future.
Wow, awesome. So you mentioned that early on in your career, you did a lot of honestly breakthrough research, which sounded really interesting. As you know, it's very important for pre-med students to have like research opportunities. What's it like actually like having a breakthrough in your research and having like building the foundation for others to like learn and grow from your own research and impacting so many?
Yeah, you never really know when you're making a breakthrough discovery in research. The best you can do, and what I really learned, from my early days at WashU, was how to get started, how to identify a problem, a question that needs to be answered, where are the gaps in knowledge, and why are those gaps so critical? And then how to pose your scientific question, your research hypothesis, and in a very structured, methodical way, go about trying to answer those research questions using that fixed hypothesis, and then finding what the end result of your experiment ended up turning out, which may be a big discovery, but may just be a little piece of information that fits into either something else you're doing, or what I really learned along the way was how your little piece of information may be the puzzle piece that was missing from a lab, 50 yards away or 500 yards away, or maybe halfway across the world, So now we really are an international community of researchers, and we collaborate around the globe. Certainly now with the internet, which we didn't have when I was in, that sort of dates me, but we didn't have that when I was starting out as a college student and medical student. But now much of our research, and the reason why it's so fast paced, is the openness. And that's the great thing about being a scientist. There's this general openness and not so much a competitiveness, but a real collaborative feeling among scientists to really help each other put these puzzle pieces together to really make that breakthrough. And then when you can actually, make that discovery and realize it may be, in the here and now that you realize how important it is. But in the case of monoclonals, it took a long time before we really realized the clinical value of monoclonal antibodies. Here it is 40 years later, and we're finally, discovering therapeutics that utilize some of the same technologies that we were using way back then.
Thank you. That's definitely a great answer that could like shed some light on hopefully one of our pre-med students making breakthroughs like that. To take a step back from the past and focus more on where you are now. So you were talking about how you were involved with the like organizations about like breastfeeding and such. And how do you get into these how do you get involved with these organizations? And then how do you balance that with just being a doctor and a teacher as well?
Yeah, great question. So how do you break through? And really the question may look, from the student and early career person as like, how do I break through? But the question that we more senior members, that are in the leadership positions of the academy have is, how do we pull people through? How do we identify those who want to be part of the organization and get involved and be part of these big projects, and then ultimately rise to the level of leadership? So we at the section and really throughout the academy now, and really now with a big interest in our most recent board policy on equity, diversity and inclusion, really have to think strategically about creating pipeline programs that allow us to tap into the interest and talent among students and then residents and early career folks to get involved. So we actually have liaisons that participate on our section on breastfeeding that are pediatric trainees, so in residency, and they're really busy, so we don't throw a lot on their plate, but they're so important to kind of keep it real. And I'm always reminded by the Office of Medical Education here at CMSOU about the book Mind the Gap. Like there's some things that we just don't know, like our generation just doesn't think the way your generation might think about things, how to reach people, how to package a message, and how to improve their education. And we need the early career folks and the pediatric trainees to help inform us. So really they're here as our sounding board to figure out if what we're doing is right. So one example is one of the things that I worked on early in my leadership role for the section on breastfeeding was developing a residency curriculum. Because again, it was one of those huge gaps to realize that most people went through pediatric residency 3 years and never learned anything about breastfeeding. And it used to sort of take my breath away. Oh my gosh, we're graduating a whole other class of residents every year in all these programs, and no one knows anything about breastfeeding. So there was this, really compelling desire to do something to fix that. And so we at the Academy decided we're going to write a curriculum that is grant funded, federally funded, and just put it up on the website and let all the programs use it, download it, use this curriculum. And we gave them activities and resources and even pre and post tests and the whole bit. And we actually tested the curriculum with another grant from the CDC to see how well it worked. And in fact, it not only improved knowledge, confidence, and practice patterns, but it also improved breastfeeding rates and the programs, they implemented the programs, so all good things. So here was this residency program, but it was kind of like a flat database. It was written very much in the eyes of the 80s and early 90s. And so now we have new funding and all these young learners to say, how do young people learn? So we're talking about things like chalk talks, and all these novel short video clips, kind of like Khan Academy, videos, to give you like the cliff notes, the visuals, all the different ways to learn about the physiology and the anatomy and the biochemistry of human milk and lactation, which is more complex than you would even think at face value, but how to teach that in a way that is exciting and interesting to new learners. And utilizing all those different platforms. So it's an exciting project, and we're learning a lot, as the sort of more senior hard copy book reader learners about how to deliver curriculum in a way that is interesting and hopefully will be well utilized.
So kind of continuing on that topic of breastfeeding, we were curious if now, due to the recent pandemic, if you've noticed any trends in like the ability of women to be able to breastfeed due to all of the extra stress that has come on due to the pandemic?
Yeah, so great question. And that taps straight into a paper that we just published in the Breastfeeding Medicine Journal. So colleagues of mine at Harvard and also colleagues from all around the world through our organization, the Academy of Breastfeeding Medicine, got together and decided to launch what we called the COVID Mother Study. So we were really interested in exactly your question. So like, what has the pandemic done to either support or interfere with moms who want to breastfeed? What were some of the practices that were happening in the hospital, and did that undermine mom's ability to continue to breastfeed afterwards? And then what's the support like out in the community? And then what do we know about whether breastfeeding is even protective, let alone a risk of transmission of the SARS-CoV-2 virus, but can it even be protective to the babies? Because if moms are COVID positive or have antibodies, is that a way to in fact transmit those antibodies to the baby and actually provide some protection? And a lot of those questions are just coming out like daily, right? There was just a New York Times report that came out today about some of the maternal antibodies post-vaccination that moms acquire. So if a mom is vaccinated during pregnancy, she makes antibodies to the vaccine. She actually passes some of those antibodies in utero to the fetus, but then also continues to pass neutralizing or protective antibodies through breastfeeding. So in response to what we learned in our research project, we were really interested in 3 main maternity care practices, because a lot of organizations at the time were saying, these coronavirus is going to be really dangerous. We know influenza is really dangerous to newborns. We know a lot about newborn sepsis. And the last thing we want is for babies to die during this COVID pandemic. And so we're going to do everything we can to protect these babies that are born during this pandemic. And so the recommendation at the time, about a year ago, was to take babies after delivery and separate them from their mom, right? So to take the baby and put the baby in a separate nursery, which is what we used to do, right? But we learned a lot about the best place for babies to be since then. And we now know that there's many health benefits to keeping moms and babies together, really physically together. So we've learned now that keeping moms and babies skin to skin for the first hour after delivery actually can help the baby's physiology, helps prevent low glucose, helps prevent the baby from having respiratory distress, helps the baby actually initiate the first breastfeed. The breastfeeding that happens in those babies actually is much more effective. And so that first, what we call golden hour, is really critical. And then after that, it's really important to keep the mother and the baby in the same room, what we call rooming in, to, again, continue to support moms breastfeeding the baby in a cue-based way. So the baby cues and then feeds in a responsive feeding manner, as opposed to waiting for the baby over yonder in a nursery to, cry really loud, only then to have to find a staff member to get that baby back to the mother. And by most of the time, by then, the baby's already been fed with formula in a bottle. And so those two factors. And then the other recommendation, in addition to not allowing the babies to room in and not allowing the babies to have skin to skin, was not allowing the babies to directly breastfeed. So they were actually recommending that moms express her milk, pump her milk, and that somebody who's not COVID positive feed the baby the express milk. So those practices were recommended by the American Academy of Pediatrics and other organizations, really without any good evidence that they were really necessary or whether or not those practices caused harm. So we're really interested in trying to figure that out. And that's why we launched the Mother's COVID study. And what we found is that those three practices, skin to skin for an hour, rooming in within arm's reach, meaning keeping the baby and mother within arm's reach, not 6 feet away, so that the mom can actually get the baby and do responsive feeding, and then being able to directly breastfeed as opposed to have to pump their milk and then feed the baby the express milk. Those three factors, if they were in place, led to anywhere from a 3 to 6 times likelihood that the mom would continue to exclusively breastfeed for the first 3 months after leaving the hospital. So really big impact. And so if you take the reverse of that and look at the harm, so what we found is that moms had maybe a 1 in 5 chance of continuing to exclusively breastfeed if she wasn't allowed to directly breastfeed, or if she had her baby taken away from her during skin to skin, or if the baby was made to reside in a separate nursery, as opposed to allowing that baby to room in. And every little piece of that actually had a trend toward being significant, meaning that the baby skin to skin has to be an hour. If it was like 20 minutes, it was a little better than nothing at all. So each one of these interventions had kind of a dose response component to them. So now we know, and most hospitals, not all still, but most hospitals are in fact practicing those 3 main behaviors: keeping moms and babies together, allowing skin to skin, and allowing for direct breastfeeding. But what we also found was that by doing what they recommended a year ago, moms had significant stress. About 75% of the mothers whose babies were separated were very stressed, or either very or extremely stressed from having that. And then we also learned that among the mothers that had their babies separated and were told to express milk, about half of them never got back to directly breastfeed. So that that imprinting, that time frame, that window of opportunity, once it goes away, sometimes it's hard to get back. And so these moms never got to breastfeed really after leaving the hospital because it was completely interfered with early on. So now we know that's the best thing to do to support mothers and babies. And we're learning more and more about the antibodies. In our study, we weren't able to show, based on our sample size, that breastfeeding actually protected against the babies acquiring SARS-CoV-2 infection. It was a very low rate of transmission anyway. Mothers who were symptomatic had a higher rate of transmitting the infection. But for the most part, if moms practice good hand hygiene and mask wearing during the time that they have their baby in hand or skin to skin or breastfeeding, the transmission rate is very low. So we're learning more about the antibodies, both through breastfeeding after being SARS-CoV-2 positive from acquiring the infection, but now again, as I mentioned earlier, even after vaccination. So the hope is that pregnant women can be vaccinated routinely, even though this is recommended to be a shared decision. It is recommended because actually there's bigger risk in mothers that are pregnant than non-pregnant women who acquired the SARS-CoV-2 infection, especially with the outcomes of the baby. There's a greater likelihood of fetal loss as well as prematurity. So really, we think it's a good idea. Women are pregnant to get the vaccine if they haven't already been vaccinated. And then if they are breastfeeding a baby, we recommend that they also get the vaccine if they haven't already gotten it. And again, people are actively studying the kinds of antibodies. It's interesting because the kinds of antibodies that you would expect in human milk are a little different after vaccination than with natural disease. And that has to do with the antibody profile. And when I think about it, and I think about studying antibodies in human milk, I think about how it sort of takes me back to my origins as a basic scientist in the lab studying monoclonal antibodies, because it really is about understanding IgM coming first and the isotype switching and how those different antibodies actually are metabolized differently in human milk and then finally in the gut as they're transferred to the baby.
So,
Sam, you want to?
yeah, just as a little follow-up. So going back to what you said before, you said that the American Association of Pediatrics released a statement saying not to breastfeed right away after delivering a child and to have the parent to be separate. Did they consult with your section at all? And what did they base their reasoning off of when they did that?
Yeah, so the main statement was written by the Committee on Fetus and Newborn, and so our section did have some input, but really they were using the evidence that they had around the fields of sepsis, and it was really out of the concern and caution that they made that recommendation. It quickly reverted, and then since last March, over the course of the last year, all of the guidance around SARS-CoV-2 from the AAP is what's called interim guidance. So anything that's written is only good for a month, and then it must be reviewed. So very different than policies, which are standing usually for 5 years. So all this interim guidance was written about how to care for mothers and newborns that are SARS-CoV-2 positive, and then what to do after they go home. The advice about what to do after discharge from the hospital was actually written by our section. And again, the most recent iteration of that guidance just came out last month. So we continue, it keeps us on our toes. So every month we're revisiting the literature, we're revisiting the evidence and issuing guidance that is a best reflection of the evidence. And that's what's great about science, is that we can actually use this evolving literature, use the evolving evidence, really ascertain what the evidence is telling us in terms of recommendations, and then issue new guidance. And I think the general public in some ways gets frustrated by that, right? So like from the CDC, it was 6 feet separation in schools, and now it's recommended 3 feet separation. And I think there's a general misunderstanding that if there's a change in recommendations, then you must have been wrong the first time, right? And that's not necessarily the case. It's really about evolving science, getting to the truth by continuing to do investigations. And I think that's what allows us to make new recommendations, to revise recommendations, to be a little clearer about what our guidance is saying. And it really is about deriving newer recommendations based on newer data sets, newer studies that are published. And with COVID, that is changing daily, has been changing daily since the beginning of the pandemic. But we need to be open to that. One thing you learn as a scientist is that, always be open to the fact that there is type 1 or type 2 error, that you miscalculated, that your sample size wasn't large enough, that you don't have external validity. All those different kinds of flaws or biases can come into play. And I think we have to be just honest and upfront about the fact that as scientists, we challenge our own studies, we challenge our own evidence, and keep wanting to go back and either validate or refine and hone what we think we know.
Wow. I just had two questions. One is you're clearly involved in like many organizations, you teach, you're a doctor, and I'm sure you have other responsibilities in other places. Do you ever feel like you're spread too thin?
Yes, that's a great question. I think, and this speaks a lot to women in medicine in general, because, we also have that role of being female, and, really as much as you try, a lot of the responsibilities of family and the household kind of falls on our shoulders as well. And so we have a new organization actually that we started at our hospital and our medical school that's bringing together academic women in medicine and thinking about ways to support each other, thinking about ways to do research that helps to empower women and yet gives windows of opportunity to really tap into all the intellectual property that women have to offer and contribute to innovation and improvement of medicine in general. And I have this slide that I developed for one of my presentations on this particular topic. And it's a slide that I actually lifted from my publications in PubMed. And it's so interesting because it kind of tells the story really quite obviously, where you see some of my publications from college and medical school, but then there's this huge gap, right? And so that was the time that I was pregnant and parenting, right? And with little kids, and that's okay, So then there's this period of time that comes after that, that you then realize your kids are older, they're in activities, and if you have supports at home, then you can sort of re-engage. But a lot of faculty have a hard time re-engaging and really trying to figure out how to jump back into the triple threat of being a physician, an educator, and a physician scientist and a researcher all at the same time. And I think it's about, just the individuality of medicine. What I've always said is that the wonderful thing about medicine is that there's so many ways to be a physician. You could run the gamut from being a clinician in an ambulatory practice, seeing patients all the time, running a practice. It's almost like a business. So you can be sort of part-time businessman. You can be an academic physician, where you're doing some residency teaching and then practicing in a hospital setting or even an ambulatory setting, maybe interacting a little bit with medical students. You can be a full-time academician like myself, where I do some clinical care. I still see patients sometimes, but it's really just a few times a month. And I spend most of my time developing curriculum and teaching medical students, or full-time in the lab. So you could work for a pharmaceutical company, you could become a politician and, be a senator or congressman. There's so many different things that you could do with your MD degree that the sky's the limit, really. So there's no one right way to be a physician. And I think it's whatever works for you. So I don't like to call it, balance anymore. A lot of people used to talk about this idea of balance. How do you achieve balance? And it's not so much, you're never really in balance. It kind of comes in fits and spurts, like there's periods of time in your life where you're all in your parenting role, and I learned a lot I'm doing that, and you know, I wouldn't ever give that up. It's sort of what I consider my greatest privilege, is to have been a mother and have been able to raise two amazing girls. So yeah, I think it's about just finding whatever really is the driving force in your life at that time, and then going with that. And I think as a researcher, you have to have this drive to solve problems and to ask those questions that keeps you going, because you know, you're not going to get those answers on a day-to-day basis. It's really long term.
So going back to when we were talking about like how you took off some time to like be a parent, what was the process of re-engagement like? Was it like riding a bike where you kind of just get back into it, or did you have to like ease your way back up into a similar position that you were at before?
Yeah, so that's a great question. So at the time, I had an actual administrative responsibility. I was chief of pediatrics at the hospital that I was practicing at the time. So I was busy administratively and busy clinically, but I could pare back the clinical responsibility in order to take time off, have children, spend a little bit more time at home. So work a few less days and do a lot of work from home. Even back then when we didn't have, you know, these Zoom calls and things like that, I could still do a lot of work remotely. But then when I came back, I think I just missed being a researcher. And that was just, I think it's just so much a part of who I am. It was so ingrained in my formative years to be a researcher. So then I just, through my organizations, made connections. I think it really is about collaborating with peers and actually doing collaborative projects. So a lot of the projects I did early on were collaborative projects with colleagues of mine that are up at Boston Medical Center. We have very similar patient populations. Our demographics of our delivery populations are almost identical. And so we're able to do some really cool clinical research projects at that time. I you know, definitely stepped out of the basic science lab. I do a little basic science now with the collaboration with our microbiologists. We're doing a little study looking at the microbiome of infants based on how they're fed. So again, part of my interest in exclusive breastfeeding and looking at the differences in the ontogeny of the infantile microbiome, which is a whole another amazing field to understand how important the microbiome is to health and wellness, and how that gets started really right from the get-go. But most of my research has been clinical research. So big population health studies or sort of clinical interventions. And then because of my interest in adolescent medicine, I've mentored a lot of students to do research in the adolescent population. And again, I have an interest in nutrition. I have a big eating disorders population. So I've had multiple students do projects related to eating disorders, body size dissatisfaction, and also with the personal history of trauma. I had one student that was able to develop a really resilience scale. So we sort of looked at the correlation of low resilience and body size dissatisfaction. So really all clinically based research. So it's really been in the last, I would say 10 years or so that I've kind of left a lot of the research work. I still do a lot of research with students, but a lot of my work is really in quality improvement. That's kind of a new science where you take what you know and the evidence and you put it into place through a very complex process that was established by the Institute of Healthcare Improvement called the Model for Improvement. And it's about making big transformative changes. So I now lead some big collaborative breakthrough series projects. One that is called the National Action Partnerships for the Promotion of Safe Sleep, making safe infant sleep and breastfeeding the national norm. I also lead a project here on campus with somewhat junior and mid-career faculty that are in primary care called the CHAMP project. I'm the improvement advisor to all of the fellows' transformative projects. So I teach them the methods of quality improvement and help to shepherd them through their changes so that their projects can be successful. So that's where a lot of my extramural types of funding comes from.
So you had mentioned earlier regarding the vaccine and pregnant women, which I thought was super fascinating, and how if a woman receives the vaccine that she can actually pass some of those antibodies onto her child. And I was just wondering how you guys were able to prove that, considering one, that a newborn baby is most likely going to be primarily at home, so their exposure is going to be extremely limited to COVID-19. And then second, the vaccine is still really new. So how would you like measure those effects past, I guess, a child a few months old?
Yeah, great questions. And I just want to clarify that it's not my lab that has been doing that work. I participate on an international working group of COVID-related breastfeeding, maternal child health related topics. We gather monthly people from all around the world and present the research we're doing. So in that group, I presented the COVID mother study, but many other investigators are presenting ongoing work from their institutions where they're able to isolate. It's not so easy actually to isolate antibody from mother's milk following vaccination. And then they can distinguish the antibodies that the baby acquires based on the vaccination compared to the natural disease, so SARS-CoV-2 disease. And these are in individuals who haven't been exposed to SARS-CoV-2 natural disease. These are individuals who were just vaccinated, and then able to test baby serum to actually look for antibodies in the babies. So these are studies, some are being done in New York at Cornell, and some are being done out in San Diego under the direction of Lars Bode's lab, and some internationally around the world, Germany and New Zealand and elsewhere. So yeah, it's technically not so easy as you suggested, but they are in fact able to identify the actual antibody derived from the vaccine. So almost as quickly as they've made the vaccine, they're already up and running doing these studies, which is just fascinating. The speed with which the labs have been able to mobilize and collaborate and actually get data and get results that can inform practice is remarkable. It's never been this fast. Science is moving so fast now in such a great way.
Yeah, that is definitely really incredible. And just to make a little bit of a transition, everything we were talking about was very fascinating and all, but we just want to get to know a little bit more about like your day-to-day life as a doctor. So like we know you don't really have an average day because you do so many different incredible things. So could you give us an example of like what a day would be like for someone in your position?
Yeah, so it really does depend on kind of the day of the week. So Mondays tend to be my patient days. So those are the days that I go to the clinic here in Camden and I see teenagers, and that's all fun. And most of them are actually coming in now. Some request telemedicine visits. So I do some telemedicine visits, mostly follow-up patients. As I mentioned, some of my patients have eating disorders and prefer not to have to travel long distances to come in, as long as they can be honest and upfront about how things are going. And then my Tuesdays and Thursdays are scholars days. So our M1 students, our first year medical students, course is run on Tuesday mornings. And then our M2 second year medical student courses run on Thursday mornings. And as the course director, I huddle with my faculty. I've got 25 faculty. We huddle with them before we run the session, just so that everybody's on the same page. And then we begin the session with the students, and it's in a setting like this by Google Meet. And each of the 11 small groups meet together. So we conduct the learning in small group. Any lecture material this year primarily is delivered to them as flipped lectures, which you guys know probably from college now, probably all too familiar with group lectures. And so the didactic portion they've already had. So the small group session we use for problems. So similar to engineering, we have problem sets that go with our biostats and epi course, and they go through the problems. And the problem sets are clinically based, and then we do some practice questions that are similar to their board-like questions with a clinical STEM and multiple choice type response. And then we set aside some time for our Q&A period with our statistician. And then in our second year course, which is really more application, we tend to either have the full 2 hours, just be small groups on topics. So for example, a lot of our courses focused on safety and quality. And for example, this coming week on Thursday, we'll be doing a session called Wrong Site Surgery. And we talk about the timeout in the OR and talk about the patient safety issues from that perspective. And so my Zoom is frozen, hopefully not on your end. So, sorry, just trying to unfreeze my Zoom.
You're good on our end.
Can you hear me?
Yeah, we could hear you and see you all right.
Okay, all right, great. I wasn't sure because it's frozen from my end. Yeah, so they'll have a 2-hour discussion about what a timeout is and what the Joint Commission is, and then go through some pretty dramatic patient safety issues and talk about ways to remediate patient safety issues, and really framing that all in what we now call as the just culture, as opposed to the blame and shame culture, understanding that safety issues are all too common and need to be addressed, and we have mechanisms to try to, what we say, chase zero, to really get to the zero error rate, which is our goal. And so those are our Tuesdays and Thursdays, and then the rest of the time during those days, we're revamping some of the materials that are going to be rolled out for the next week, writing exams, and then going over some of our student evaluations and our course reports during that intermediate time. Wednesdays, we have liaisons, so our students in each of the years meet with us and get to tell us, what's not working, sometimes what's working in the curriculum, and give us some feedback on a week-to-week basis. And then we make adjustments based on the student feedback. And then Wednesday is also the day that we have grand rounds and department meetings. So our pediatric department meets, our infant feeding quality committee meets on Wednesdays. And then in the afternoons, I spend most of my time with my different projects. So my Naps In project, as I mentioned before, or my HRSA TAMP project is a Wednesday afternoon event. And then Fridays are the day that we have our CIF global committee with the folks all around the world working on COVID-related research. And so we gather and talk about new studies and what people are doing and how to collaborate, which is a really awesome opportunity, a lot of fun. And then the rest of the time on those days, in the midst of revising abstracts and manuscripts, we're putting in a few abstracts for the American Public Health Association meeting, putting in some abstracts for the Academy of Breastfeeding Medicine. I'm presenting at the Pediatric Academic Society's meeting, so preparing that talk. And then I have grand rounds coming up from my department that I'm delivering after the holiday break, so like on April 7th. And then I'm giving some other talks related to mentoring and quality improvement. So that's sort of my week. I do a lot of things sort of outside the general week. There's a lot of weekend time and evening times too, because it's a lot of writing and reviewing and editing and communication. So my colleague that I'm doing research now with in Boston, we do Zoom meetings and try to figure out how to do some data analysis that way. And then with all my students, I have about a dozen medical students that are my capstone mentees, and we find times all throughout the week to meet by Google Meet or Zoom to go through their projects that I'm mentoring them on.
That is an impressive schedule, if I don't say so myself. We don't want to keep you too long, so we just got a couple more questions to wrap up. And these ones are actually, I think you'll be a great person to ask them because it's more about like the education side of med school. So are a lot of the classes in small group-oriented settings where it's like pretty structured with problem solving and smaller discussions? And then just to wrap it up, how have the shortcomings of being online affected med school educations?
Yeah. So the first question in our medical school, we have a dual integrated curriculum where we have our block courses where material is delivered either in flip lectures or didactics or in anatomy lab with the anatomy components of whatever block they're learning about. But then overlapping that on the alternate days of Scholars Workshop, Monday, Wednesday, Friday, all of our students in M1 and M2 have active learning groups. And those are problem-based curriculums that involve cases where they have releases and they're using their self-directed learning skills to be able to solve the cases, and they directly integrate with all of the block courses so that they're learning the didactic material, but they're always applying it to the cases in the ALGs. And the ALGs are supervised by a clinical faculty member and a basic science faculty member together as a pair. So, so there's always that synergy, of the basic science perspective along with that clinical side. And then some of our faculty are both, they have the PhD as well. And so they're both clinical and basic science faculty. And so the first 2 years then culminates, with the step exam, and then the students go out into their clinical blocks and their clinical clerkships. And every Friday during the clinical clerkships, they kind of come back and do what's called transdisciplinary. So they take what cases they've learned about and then reintroduce the basic science concepts or any other concepts around social determinants or health equity or anatomy or pathology, whatever else they think can be integrated within that clinical learning on the Friday cases. And your last question, I've now forgotten. So
it's how is being online with the pandemic and everything the learning experience?
Great question. So yeah, it was a big hurry up and get this done when we realized that we were no longer going to be able to meet face to face, and so much of our learning was done in small groups, and the rooms were just not big enough to be able to accommodate the students, the number of students and faculty that were in those active learning group rooms. And the building literally just closed down. So we just jumped using several different platforms. We tend to use Google Meet for our smaller groups because it's kind of a more user-friendly platform where there's no owner and everybody can share. And if somebody's sharing something and you decide you want to share, you can just take over and share. So it's really democratic in that way. And so that's how we've broken up our small group learning, is using Google Meet. For a lot of our synchronous didactic learning, we'll tend to use WebEx because you can control that a little bit more, on the delivery end and on the presenter end, so that there isn't a lot of background and everything. And then we can capture those with recordings. So we keep all of our lectures on Echo 360, so you don't have to attend synchronously the lectures, and you can actually go after the facts. All of our lectures in Scholars for Biostats and Epi are all delivered as Flip and just all put directly into Echo 360. And so I don't want to say it was seamless, but surprisingly doable. Even anatomy, we were able to conduct virtual dissections and really deliver the curriculum in a way that we don't think our students really lost too much, in doing the curriculum that way. The big hit, I think, was in the clinical clerkships, just because there was a lot of restriction initially about students coming in if they were going to be exposed and put themselves at risk, and yet weren't really contributing to the care. So that has gotten better, certainly now with our students being vaccinated and actually being the vaccinators. They actually have done an amazing job in being the vaccinators and helping out in all the different vaccination sites around the area. I think they were the single key ingredient to helping to get as many people vaccinated as we have been able to get vaccinated. So I got my vaccines by all of our students. So, it was a great thing for them to be able to do and participate in. So now they're back in the clinic and they are getting their clinical exposures, but it was really hard. And I think it was hard also on our M4s because they were restricted by their fourth year, typically doing away rotations, which tend to be rotations where the students have an opportunity to meet program directors from places where they want to train. And they didn't really get to do that. And so they were now all held back in our institution, and we couldn't offer really the same amount of experiences that they were going to be getting with those away rotations. That said, we had probably one of our best matches ever. We have a much higher match rate than the rest of the country, like over 98% match rate. And we matched in like all the really difficult fields in plastic surgery and dermatology and orthopedics and neurosurgery. So, and at amazing places like almost every one of the Ivies. A lot are grown to Penn, but some Dartmouth, Brown, Cornell, and elsewhere. So, and some of the military folks, matched at amazing military programs as well. And we have someone going out into family medicine in Alaska. Her dream job was to be a do everything family medicine physician all the way out in Alaska. So yes, so far away. So I think, whatever we did worked. It's not our choice. We'd much rather be in person. I think it took a lot. We started in the same time frame as Center for Humanism, really focusing on wellness, not only of our faculty, but of our students, and understanding that the pandemic has taken such a toll on the mental health of everybody in the healthcare system, all throughout the healthcare system. Cooper's done a ton in terms of really promoting wellness and telling the stories of our frontline workers, primarily nursing staff, but also the criticalists and other hospitalists that have been on the front lines during the pandemic. And they have created their own podcast and sharing these stories, which are really heartfelt and great to listen to and to hear about their triumphs.
And do you know the name of the podcast by any chance?
So it's Cooper Hospital Podcasts.
Okay.
Something about stories. I can find it and I'll get back to you.
All right. Yeah, we'll definitely put that below the video or something. And thank you so much for your time. And I think it's amazing all the stuff you do and hearing about how well Cooper's doing, especially with that match rate. That's incredible. I just want to say thank you for coming on.
It's my pleasure. It's great talking with you guys.
Thank
Good
you
luck.
so much.
Thank you, Dr. Winter. I just want to say one thing. At one point, you mentioned something about how there are like so many opportunities in the medical field. And like, that's basically like the thesis of this podcast is like, it's for pre-med students just to learn that you don't have to be a surgeon like Grey's Anatomy, and you don't have to be one type of doctor, but there's so many opportunities and you can find your passion somewhere and it'll all be great. So thank you.
Yes, you're welcome. Yes, the MD degree can take you lots of places. and all good.
All right, have a good night.
All right, it was great talking to you. Take care.
Take care. Bye.